Okay, so welcome everybody to this session on strategies to support caregivers. Carers have been important since the outset of the focus on dementia care. They were fundamental to the establishment of many Alzheimer's organizations. And this slide illustrates very briefly why they are so important today. In high-income countries, about 70% of people with dementia live in the community. And in lower-income countries, that figure, of course, is a lot higher. And without that support, people with dementia simply wouldn't be able to live in the community and enjoy a quality of life as they would wish. In economic terms, informal carers equate to more than 40 million full-time workers, as estimated in the World Alzheimer's Report on the global impact of dementia in 2015. Carers found their way into the Global Dementia Action Plan in Action 5, and there is a target which you can read on this slide. It's not a very ambitious slide, perhaps, compared with some of the other actions in the plan. And that perhaps is a bit typical in terms of policy in respect of carers worldwide. So this slide is simply to illustrate that the way health and care systems are organized touches on the lives not only of people with dementia, but family carers, from diagnosis through to palliative care. And issues such as coordination and case management are essential for many carers in getting access to the complex care and support they need for the person they're caring for. It's worth noting too that depending on the country, there is a great range of supports and programs for informal carers, and more than one of the supports and programs shown here will be available in most countries. So, informal care is a complex policy area, and the strategies are going to vary greatly by high-income countries and lower-income countries. We have 3 speakers who will talk for about 15 minutes on these 3 issues: the research evidence available to determine effective interventions to support informal carers of people with dementia, innovation and technology in carer support, and the translation of research into practice. And after those presentations, we will have a response from Professor Henry Brodaty to the presentation, drawing out some of the key issues as he sees them. So with that, I'd like to introduce our first speaker, Distinguished Professor Laura Gitlin, Dean, College of Nursing and Health Professions at Drexel University, USA. Laura will talk about what is the evidence for home and community-based interventions. Laura, the floor is yours.
Thank you, Dr. Rees, and thank you to the Alzheimer's Disease International for organizing this important symposium. As indicated, I'm going to talk about the evidence and what may be ready for translation and wide-scale dissemination. This is an area that actually has had tremendous research activity, and I will try to summarize that for you. These are my funding sources, and I am grateful to many different institutions for funding some of the research that I will report. And one research study that supports carers and people living with dementia is called the Tailored Activity Program, and my institutions and myself do have rights to a royalty from online program, and I will be talking about this very briefly. So just 3 areas I'd like to cover. First, what is the evidence for different kinds of supportive approaches cares of people living with dementia, living in the home and community. I'd like to highlight some of the limitations of the evidence and then share with you some emerging programs that are very, very promising. So I'd like to first just start by recognizing the diverse needs of family caregivers and how they change across the trajectory of the disease, which we know may last for many, many years, out to 20 years or more. I won't go through each of these categories, but merely for you to see that at each stage, different kinds of needs are manifested for the family and specifically the family caregiver, and consequently, a range of interventions have been designed to address, to try to address unmet needs. However, the literature primarily, the research primarily favors a moderate stage of dementia in terms of supporting family caregivers, which is already an indication of the different kinds of research that's needed, because you can see already here, even at a preclinical and mild cognitive impairment, caregivers are missing days at work, expressing anxiety and depression. So this is an area certainly that we need more research on. But what is the evidence? As I said, this is an area that going back over 50 years of very rigorous research, with a recent report indicating that the studies since 2015 have really been elevated in their scientific design and are in process. And so we look forward to yet another whole group of very rigorously designed and tested caregiver supportive approaches using randomized clinical trials. But I wanted to highlight a recent report by Cheng and Zhang in the British Medical Journal, which shows the number of systematic reviews and meta-analyses of this body of literature. And there's so many randomized trials that you can see that the review of them has escalated over time. And I'm going to be sharing some of the results of these systematic reviews and meta-analyses. But again, this graph gives you a sense of the magnitude of this, this area. And I'd like to highlight this because, as the other speakers will address, most family caregivers in the United States and in other countries, but very much in low-income countries and the United States, do not have access to the evidence that we know and has been generated by high-quality research. So first, I'd like to bring to your attention two very important reports that were just published. One, I will tell you, is rather controversial in the United States. This is a report by the Agency for Healthcare Research and Quality that was published in August 2020, and it was commissioned by the National Institute on Aging. And their approach to a review of randomized trials is very rigorous, and we could debate the whether we agree with their application of criteria for bias. But the report basically asked, what is the evidence for interventions ready for broad dissemination? And their strict methodology is hotly debated. Their analytic set included 100 studies that were at what we call a phase 3 randomized clinical trial, and 527 studies that were looked at for an understanding of what elements of an intervention might work and what was going on, but weren't included in the final set. But the main finding, to the disappointment of many, and many of us do disagree with their analysis and their approach, is that there were no clear answers about which interventions offer consistent benefits, and that overall, the evidence of these 100 studies were of low strength, again, because of the standards that were applied in terms of needing to have double-blind procedures and other kinds of elements. There was one approach called the REACH2 intervention, which has been replicated in other countries and has been modified, which rose to the occasion to be mentioned as having some evidence, particularly for reducing stress and burden. But I can tell you the original REACH-2 randomized trial demonstrated benefits primarily for Hispanic and white caregivers only in the United States and not for African Americans. But it has been replicated in Hong Kong and in other countries. The other report I would like you to be aware of recently came out, commissioned by the Lancet, led by Dr. Livingston in England. And this report is a very comprehensive review, very, very important. It's an update of their 2017 report. I am one of many other researchers, and this was, it's a beautiful report by Dr. Livingston's, under Dr. Livingston's leadership. And as opposed to the AHRQ report, they use what's called a triangulation framework, where they're looking for consistency of evidence from different research lines. And then the report summarizes the best evidence using a more quality-oriented systematic review of systematic reviews, meta-analysis, or individual studies. And they present a synthesis of the evidence. And some of their key findings is that well-being should be the goal of dementia care. As Dr. Rees indicated, people with dementia have complex problems, and thus caregivers have complex and unmet needs. The best evidence suggests that interventions for carers need to be individualized and person-centered. Psychosocial interventions that are tailored to family needs do seem to address certain areas such as reduction of neuropsychiatric symptoms and also distress in family caregivers. And then there are other findings. So, but those are some of the ones that I wanted to highlight. Now, we have also looked at a number of systematic reviews and meta-analyses, and our conclusion is a little bit different than the AHRQ report. So in contrast to those reports, I want to now just very quickly go through other reviews of reviews. This is one that I conducted with a colleague of mine, where we reviewed 24 studies totaling with 200 different support programs for carers, including 8,095 families that tested a wide range of interventions such as professional support, psychoeducation, self-care, with most being multi-component. And these studies collectively looked at caregiver knowledge, burden, self-efficacy, depression, and also outcomes for the person living with dementia. And what we find is that overall, the evidence is strong, but small but very important changes in reducing caregiver burden, improving caregiver knowledge, reducing caregiver anxiety and depression, and delaying time to institutionalization. Here is another meta-analysis of 15 randomized controlled trials, again for family carers. And what I want to point out by this slide is that of these 15, a handful on the left side indicated a reduction in burden scores, which you can see any score lower than 0 is favoring the intervention group. And another group, a subgroup of these 15, had a positive impact on depression of family caregivers. And as well as another group within these 15 studies, reduced health, had favorable, health scores for family caregivers following intervention, and improved social support as well. So what's important about this particular meta-analysis is that, again, we see of just these select studies, for example, different kinds of support programs are highly effective. Most of the most effective interventions are multi-component, meaning that they address multiple unmet needs, if you remember my slide that showed all the unmet needs, and that they combine education with counseling and stress and skill building and mood management. But what's really important too, from a translational perspective, is that there wasn't one program that was effective for all desired outcomes. And thus there isn't going to be one magic program that can do it all or meet all the unmet needs of family caregivers. And so here is a very interesting meta-analysis just published in 2019 in BMJ of just the role of various protocols that are delivered by occupational therapy. And we can see here that, on the left-hand side, very positive outcomes in terms of reducing the amount of assistance that the person living with dementia at home needed for basic activities of daily living and instrumental activity of living. And then on the right-hand side, we see this group of studies reducing distress with neuropsychiatric behaviors for family caregivers. And what's important with, particularly with the reduction of the need for assistance for people living with dementia, is that that's another indication of burden of families who are helping a person living at a home to dress, to groom, to bathe, to toilet, and so forth. And so here we see a collection of interventions tested in different countries, primarily with the lens of occupational therapy frameworks and strategies that are very effective. But there are key limitations to these studies. And by the way, I could have gone on for many slides showing results of different meta-analyses. I just selected these as a handful. First, the literature overall, the research in this area overall is limited in that very few, except for some of the most recent studies, have been looking at cost and health utilization. And that's very important, of course, when we want to translate these studies for delivery in big health systems. They're limited in terms of understanding which groups of people do they most benefit. We know for REACH 2, for example, the best benefit in terms of reducing distress was with Latino populations, but not with African Americans. Some of the samples are poorly characterized, which really we could clean up right away. So there are some studies, randomized trials, that are still not characterizing the family caregiver in terms of race, gender, age, where they're at in their trajectory of care, and also in terms of their unmet needs. Many needs of families are going unaddressed. Most studies are not examining the physical burdens, particularly at the moderate or severe stage, or the financial strain, which we know is huge. And then why are these interventions working? And that is unclear. So most have a theory base, but we haven't really tested and looked at mediators to really understand what components of multi-component interventions are important. And so these are just some of the key limitations that I would argue have limited the translation and dissemination. And still, of course, what we do know is mostly unavailable. Practitioners are not necessarily aware of these findings, or families, and families are not either. I want to now just highlight very briefly and quickly some promising interventions that I've been working on with my teams. And the first is the development of an online application called the We Care Advisor, which provides a systematic approach to helping families identify a neuropsychiatric symptom that they are managing and want strategies for. And through using a particular algorithmic clinical reasoning process we refer to as DICE, the caregiver is asked to describe, investigate different kinds of potential causes for contributors to the neuropsychiatric behavior. And then a We Care prescription is created, which is a tailored set of strategies, and the caregiver is asked to try and then evaluate what worked and what not. And through a beta test involving 57 carers from 2 different cities in the United States, we show that the We Care Advisor resulted in a reduction in caregiver stress after 1 month. After immediate use. There was incredibly high usage of the application. There were within group differences and between group differences. So when our waitlist control had access to the online platform, they in turn had benefit in terms of caregiver distress being reduced. We've been taking some of the elements of the REACH study, REACH multi-component intervention and other interventions that we've worked on and put it together in what we call the Adult Day Service Plus, which is a introduction of systematic caregiver support and skill building within adult day services, which is a very important service to families living with dementia. And while it provides an opportunity for working families to have a safe place to have their relative with dementia stay for the day, there is not typically, at least in the United States, supportive services for them. But by having staff provide very systematic, protocol-driven approaches, we see that over time, those sites that introduce care, we call it the Adult Day Service Plus study, there is an improvement in caregivers reporting their ability to manage neuropsychiatric behaviors. There is a reduction in their depression. And we also see, this is a survival analysis of the number of days used by caregivers who receive the support through the ADS Plus program, and they are using adult day services 37 more days, which is a win for the adult day service because they do generate more revenue. It's a win for the person living with dementia because they're in a safe community-based center that provides meaningful activities. And also we found a 50% reduction in nursing home placement. So it's a win all around. And we also have found in other studies that for caregivers who do use adult day services, that there's a 49% reduction in their missing of doctor's appointments for their own health. So adult day service is a very important intervention, which we can boost, if you will, by providing systematic care support. Just another trial that we conducted showing that if you, through 10 sessions run by an occupational therapist and a nurse, we are able to work with families to identify the most pressing care neuropsychiatric symptoms that are problematic to them, and that over time, through what we call the ACT approach, families reported that behaviors were being managed better or getting better, if you will. And we introduced strategies such as structured routines, introducing activities that match the interests and abilities of the person. And we also see tremendous benefit for the family caregiver. We see that by giving the caregiver knowledge and skills about neuropsychiatric symptoms, we improve their mood, we decrease their upset with behaviors, we decrease their subjective burden, we increase their ability to manage behaviors. We see a decline in very harsh, negative communications towards the person living with dementia, which often further creates agitation, and we just see overall improvement in their management skills and just their overall well-being. And then finally, I just wanted to mention a program that we've been conducting. It's now gone through about 5 different randomized trials. It is being used in multiple countries. It's called the Tailored Activity Program. It's delivered by an occupational therapist or a health provider who has access to an occupational therapist who conducts an assessment of a person living with dementia's abilities and their best functioning and their interests, and then instructs caregivers how to use activities tailored to abilities and interests. And we've reported outcomes in different trials related to a reduction in neuropsychiatric behaviors, a reduction in the amount of time that carers spend in providing hands-on care. And I just wanted to show you some data that just is now under review from a trial we just finished in Baltimore that shows a reduction in comparing the Tailored Activity Program to an attention control that just received a home environmental assessment for safety and basic dementia disease education, we see a reduction in the death of the number of persons living with dementia who were in the TAP program. We see a reduction in hospitalization by 6 months. We see a reduction in caregiver hospitalization, a reduction in caregiver depression. And we find that the caregivers in the tailored activity group had 32% less health-related events. So we think these findings are exciting. So I just want to say, in developing and implementing interventions for carers, there is a life cycle. It occurs over time. It takes time. And what I've been talking about is stage 2 primarily, and stage 3. This is a particular stage model put forth by the National Institute on Aging. But we have a lot of evidence at the stage 2 and stage 3. And we are now moving, for example, for our Project ACT, our Adult Day Service Plus, our TAP, into what we call translational phase and testing it in effectiveness trials to move forward with dissemination. So I would just like to conclude by making a few points. Depending upon how you evaluate the literature, you may come out with different conclusions, but I would argue that we do have right now a strong evidence base for supporting carers. We know certain principles, such as tailoring to needs, really important, such as using multi-component approaches is really important. And these are strategies that we could make a difference now in the well-being of our carers. But we do have a bottleneck in the pipeline from discovery to full implementation and scalability. We need different approaches for rapidly moving what we know works into different real world settings. And we also need to make the evidence better. We need to heighten clinical relevance by looking at cost and cost effectiveness, who benefits and why, and understanding why what we do works. And I should also say, and I hope you did see from some of the earlier slides on the meta-analyses, the effect sizes are often small. So that means there is noise and other things going on, and there is a lot of room for improvement in terms of the research that we conduct at the efficacy stage. And with that, I thank you again very much for having a focus on carers and helping us understand the evidence and what we can do now to make a difference in the lives of families. Thank you.
Thank you very much, Laura, for that wonderful overview of research in support for informal carers. It's so important that policy people and service providers are aware of the evidence base. Perhaps even more important, that they're aware that there is no silver bullet, and the complexity of services if you're going to respond to the individual needs of carers and respond to the assessment of carer needs. So let us move on now to our second presentation, which is by Rose-Marie Droes from the Department of Psychiatry, Amsterdam University Medical Center. Rose-Marie will talk to us about innovation and technology in carer support. Rose-Marie, the floor is yours.
Thank you, Glenn. And thank you for inviting me. I'm going to talk about innovation and technology in carer support. In 2005, I made an overview of, based on the literature, on all the needs, and you already saw it also in the presentation of Laura. There are a lot of needs that carers who are supporting a person with dementia experience. And these vary, of course, from information to respite to financial support to dealing with a changing relationship and good contact and collaboration with professionals. When we look at this overview of needs and I look at the dementia monitor, which has been done in the Netherlands, conducted in the Netherlands in 2018, you see that the top 5 most used support by carers is information, instrumental support, activities for the person with dementia, case management, and also help in householding. And you see in purple also other types of support which are used, but much less, except from the social support from their own network. For people with dementia who are cohabiting with a carer, it's about 40%, and for people living alone, it's about 70%. When we're talking about integrated dementia care, there are, of course, a lot of different aspects which can also support the carer. But specific support for the carers, that's the point we're going to discuss today. Here you see all the other types of support, which are, of course, important in integrated dementia care, but I will now focus on the support for carers. When we look at this support and the development in it in the 1980s, you see that the focus was mainly on respite care, on support groups and home care. And when we go to the 1990s, you see that there are developments into telephone support, training courses for coping with stress, dealing with behavioral and mood symptoms, also communication skills, counseling. First meeting centers were set up with dyadic support interventions and Alzheimer cafes. And after 2000, we see even more developments, online courses, case management, multi-component interventions, combined interventions. And the last 10 years, we see that there is especially more development in the combined multi-component interventions and internet-based support interventions. And those latter two I will focus on in my presentation. There are a lot of effective programs for both the person with dementia and the carer. I must say, proven effective within studies, and some studies have been done several times, repeated studies, and some studies has been done only once. But you can see that in the picture over the world, there have been effect studies in Canada, in the Netherlands, in the USA, and they were all about multi-component programs delivering, for instance, case management or education, support, and also skill building, occupational therapy. Laura also mentioned some of these interventions. In 2000, between 2000 and 2009, you see, for instance, the comprehensive early home care program, the meeting center support program, an intensive treatment program in Germany, family networks in the United States, and occupational therapy in the United States and also in the Netherlands. And again, between 2000 and 2009, an early tailored counseling intervention, early interventional group intervention in Germany, in Japan, an empowering intervention, and family care's collaboration in Finland. And the last 10 years, we see mainly developments also in Europe, but also in China, for instance, a comprehensive education and support group for carers combined with intensive case management and professional support, integrated reactivation and rehabilitation in the Netherlands, integrated sessions for persons with dementia and carers in Denmark, the meeting center support program, which was adaptively implemented in Italy, Poland, and the UK, but later on also in Australia. The individualized meeting center support program, which I will explain a little bit later, and art programs in museums in the USA and in the Netherlands. So a lot of programs. I'd like to tell you a little bit more about the individualized meeting center support program, which is has been carried out by my own research group. We know, of course, the meeting center support program. It's a combined program for people with dementia and carers with a social club and and discussion groups and in information meetings and counseling, and also social activities for the people with dementia and the carers. But the individualized meeting center support program was set up because a lot of people don't want to go to a group for support. So this is an individualized program, which is an outreaching program for people living in the community. And the carers can receive telephone coaching or an online course or about dementia, the STAR e-learning course. And on the right side, you see for the people with dementia, volunteer work in the community. And so it is discussed with people with dementia what they would like to do. And based on their talents, contacts are made in the community to see if a person can work there. And here you see several examples from people working in set construction at a sport club and in a daycare for kids. And what the nice thing is that the people with dementia show less behavioral and mood problems. But what you also see is that the carers experience significantly less emotional burden and feel happier. Also because what the quote says, she is happy and she brings that feeling back home. So they have another perspective in their life. The Meet Me at MoMA project is a project with museum tours, guided tours in museums. And it was set up by the MoMA Museum of Modern Art in New York. And what you see also is that it's both for the person with dementia and caregivers to come to the museum. You see that both have nice effects on their mood and social contact. But what you also see is that by visiting the museum, people get inspired to do other activities together as well. And that's, of course, very interesting because then they are not focused only at providing care and on the illness of dementia. We repeated that study in the Netherlands, but focused a bit more on the implementation aspects. And we called the program the Unforgettable Program and implemented it in 11 Dutch museums. And what we saw is that, again, participants felt the program very stimulating. And overall, the satisfaction was rated with an 8. And when people entered the museum, they were happy, but after it, they were even more happy. And the caregivers were, at least 27% of the caregivers were surprised by the reaction of their loved ones with dementia in the museum. And also their interaction with the other participants during the tour. And they appreciated the different type of contact they themselves as a caregiver had with the person with dementia. So what we see in these combined programs, and in the previous lecture, you already got a flavor of this as well, that there are a lot of effects both on the person with dementia and on the carer from these combined programs. But what we also see is that besides the carer support, more attention is being paid to the social health and the positive experiences for people with dementia and carers. And so yes, in my opinion, further implementation and dissemination is very much recommended and also needed. So when we go into the developments in e-health, there are, let's say, 4 groups of interventions focused on information, practical support, emotional support, and social support. First of all, the digital information. Well, you know, of course, that there is a lot of information available on the internet by the Alzheimer's associations or web-based health and social care services, information on living well with dementia, online courses, movies on YouTube, which explain you how to deal with all kinds of aspects of dementia and its consequences, electronic patient files. But what we see is that about 60% of the carers use this information on the internet, but also that they are relatively younger, have a higher education, has less carer hours and more stress experience. And of course, we need to think about these aspects because not all carers will find the information we are disseminating. So also other ways of information are still necessary. When we talk about practical support, you can think of all kinds of products which you can buy in shops on the internet. You see here an example of the Alzheimer's organization shop in the UK. The Dementia winkel is, for instance, a shop in the Netherlands. You see links to websites which provide recommendations on guidance on accessible touchscreen apps for people with dementia, and also Alzheimer products. But of course, there are also more advanced smart home technology, sensor technology products, which are aimed for monitoring and safety. And then you can see, it's a nice example here, your grandma activities on a distance. Did she eat? When did she go to bed? When did she get out of bed? And then you get an idea of everything is okay or not. A nice new program, which I'm involved in as a project leader, is the Find My Apps program. And Find My Apps is carried out within the innovative training network from Distinct. It's a Marie Curie project in which 15 young researchers work on technology for people with dementia. And the Find My Apps program is a person-centered selection tool in combination with an online training, how to use the tablet and how to use Find My Apps. The idea is to find and use dementia-friendly apps which focus on self-management and activities and social participation. But the focus is not only on the person with dementia. It is, again, a combined program which is used by people with dementia and the carers. And we also expect positive outcomes for carers on sense of competence, self-efficacy, and experience burden. Then about emotional support. Of course, there are, again, several possibilities offered by, for instance, the Alzheimer associations, the telephone support and advice, but there are also more intensive telephone coaching programs like the Mental Coach in the Netherlands, but also social media, communities, web-based peer supports, different types of care courses to prevent mental and physical health problems in carers. One example is eye support from the WHO. Another one is the STAR online course, stress management training, but also blended care interventions, where there is, for instance, a digital course, but also in combination with a coach, so a physical coach. One of those examples is the caregiver imbalance intervention. I'd like to say a little bit about experience sampling, because this is a kind of personalized feedback method, which has been used in research to provide carers personally tailored feedback on daily patterns and activities, and which also informs about the context and the related emotions. And by giving this feedback, the aim is to increase activities that generate positive emotions to build carers' personal resources. So that's also a way in which you can support carers. And this way of intervention, way of support was investigated by the Partner Insight study by Van Knippenberg, and later on also Bartels did research on this within the innovative training network Adjunct. So that was a previous network before Distinct, and it was led by the Maastricht University, this Partner Insight study. Then finally, the social support. There are, of course, many websites in which voluntary helpers are matched to care requesters. So that's a very low threshold way to find someone that can help you. Another way is sharing the care. So sharing the care with your own social network. An example of this is ShareCare, and another one is In Life, for instance. So then you can share the agenda, but all kind of activities which you can offer or which you can see that your mom's involved in, for instance. And it will help to improve the collaboration between the social network around the person with dementia and the carer. So to conclude, there have been done quite some effect studies. It's increasing the last decade, but they have generally low to high quality. So it's very different. This makes it difficult to generalize the results. The effect sizes are small to medium, and therefore further research is needed. The multi-component interventions have the best results. That's the same as Laura Gitlin said. Also in the technological internet-based interventions, multi-component interventions work the best. And I think the core is that they give attention to information, practical support, emotional support, but also social support. So this combination is really needed for people who are caring for a person with dementia. And of course, it's important that they are tailored to the individual needs of carers. And then we see that they can have a nice effect on the well-being, for instance, confidence, depression, anxiety, self-efficacy, and carer stress and competence. When you look at information online, this also proved beneficial, but when it was part of a multi-component intervention. Only information provided is not really helpful. So it needs to be tailored to the individual, and it needs to be part of a more multi-component support intervention. When we look at online contact with professionals, that is very much appreciated by carers, as it provides easy access to personalized advice and emotional support. Then regarding psychological support, we see that the carer's mental health improve. And regarding the effectiveness of practical support of carers by utilizing dementia-friendly apps, for instance, is yet still unknown, but the first pilot studies are promising. So further evaluation and sustainable implementation in organizations of internet-based support, if effective, of course, is very relevant, especially also in COVID-19 times, but also thereafter. Thank you very much. It was a pleasure to give this lecture, and I think there is a whole lot available for people with dementia, but yes, indeed, further implementation is very important. Thank you very much.
Thank you very much, Rose-Marie. That was a really wonderful presentation because it was so accessible and easy for a policymaker like myself to actually understand, which is always a relief. I suppose the thing that I enjoyed being of an age of having sort of taken an interest in aged care from 85 was the evolution of the programs and really the increasing complexity in an effort both to get flexibility into care as well as to respond to individual needs. And I think that's a really important thing for policymakers and service providers to understand, that individual programs that aren't flexible really aren't going to meet the needs that we have.
Yeah, I think too that's very, very important. Yeah.
So let us move on now to our third speaker, who is Claudia Cooper, Professor Claudia Cooper from the Psychiatry Department, University College London. And Claudia has the very challenging task of talking about the translation of research into practice. Claudia, the floor is yours. Thank you.
Thank you, Glenn, for that introduction, and thank you to Alzheimer's Disease International for the introduction. Here are my conflicts of interest and funding. one of the things that I'm working on particularly at the moment is developing complex interventions. And this talk very much follows on from the others, thinking about how all that very helpful work that we've heard about in developing flexible, multi-component, complex interventions to support the family carer and the person living with dementia together. How do we ensure that this research gets used and gets adopted into practice? Because like many of us, I'm sure, who work in a clinical context and also as a researcher, there is a sometimes difficult to navigate gap in between. And what is adopted in practice isn't just a product of research studies, however efficacious our interventions are found to be. But there are also many other complex drivers that influence the extent to which things get implemented. And of course, one of the important things is the context in which we are seeking to implement. And for a global community such as the Alzheimer's research community, what I find very interesting is how we can take the many successes from other countries and make them work in our own context. And increasingly, when we run big research programs, there's an appreciation that the ultimate goal of implementation needs to be considered right the way through. And we have helpful sort of conceptual frameworks for that, such as this consolidated framework for the implementation of research, which we're using in our current work. And this encourages us to really think from the beginning, what is core about what we are doing? How might it be adapted and flexible? And how might it work in the many different settings, possibly in many countries, where we foresee our research being useful and used? So what I'm going to talk about today is how we make that journey from the artificial world of the research trial to our clinical services as downhill and easy as possible. And I'll be thinking about this in three different areas. First of all, context, because obviously context is everything. How do we ensure that we understand enough about our research populations, and how do we make them as representative as possible? Whenever any service is thinking about how to implement research, they need to know how it works, who delivers it, who supervises them, how does it work in practice? And so I will ask, how do we ensure that our research studies are organised in a way that is as translatable as possible? And also, how do we consider from the outset the end users of our research, and how do we ensure that the many different organisations that we want to actually use it? So taking the context first, when you think about the many family carers across the world who we may want to benefit from our research, unfortunately, to actually get to take part in a research trial, as many people want to do if you ask them, is quite a narrow door. And we did a review a few years ago now, asking of people that are initially approached about research studies in dementia, who actually takes part. And about 50 to 60% of carers that we asked to take part in psychological intervention studies say yes. That hides the multitude of decisions that are made before the point of approaching, in which there will also be inequalities and biases. But generally, if you look at our research populations, they tend to, the carers that take part and the people with dementia that take part are often younger, with more education from the white majority population backgrounds in Western countries, and men and people who are English speaking are generally more likely to be taking part in research studies. So what can we do to make those populations as representative as possible? Because ultimately we want to deliver research that we know works for the people that are going to be using it. And there are a few interesting studies that are going on or that have reported that have really sought to look at that from the other side. And I'll talk a little bit about the START intervention on the next slide. But this is something that has been very successfully adopted in the UK as an intervention to support family carers. And Jill Livingston and colleagues are currently looking at how is that research being implemented in the South Asian community. And we originally, in the original trial, it was delivered by psychology graduates, but how might it work in the third sector? So even when the effectiveness trials are done, there is much more work going on from that to think, how do we ensure that this is embedded in a helpful way? I found this study by Tilburgs et al. Very interesting as well, looking at the implementation of advanced care plans, because I could really identify with this, having sat in clinic, thinking about how you make decisions about what interventions to put forward. And I think inevitably there are fewer barriers to involving dyads who are motivated with relatively little burden, perhaps, in taking part in innovative interventions. And I think it's something that we really have to acknowledge and try and challenge, because we have these many useful tools, and it's so important to try and get them out there to as wide a population as possible. So going on to think about the how of how we deliver our interventions, and certainly most large trials now have process evaluations embedded, because we've realized that it's not just whether it works, it's how it works. When we were applying for money to do the Strategies for Carers grant in the UK, which Jill Livingston was PI for, we were very interested and inspired by the work of Gallagher Thompson in the USA on the Coping with Caregiving program. And I remember I was doing my PhD at the time and learning all about it. And we thought very carefully about how to take that successful program and make it work in a UK context, and how it would need to be delivered and who by, in order to make it work in the UK NHS setting. And so with permissions, we adapted it for individual delivery and by non-clinical graduates who were trained and supervised by clinical psychologists, whereas the original intervention was group and delivered by mental health professionals. And I often think of that when talking about this area, because as far as possible, it's so key to think about your target end users when designing studies. The PRIDE study is another big study in the UK, and this was actually an intervention delivered directly to people living with dementia, but I had the honour of writing an editorial for this recently, and so spent a bit of time thinking about it. And one of the things that the PRIDE team led by Martin Oral did, which was very admirable, was to think about the organisations that would be delivering their PRIDE intervention if it was successful. And so they directly evaluated it, delivered by dementia advisors, employed by NHS trusts right from the outset. And however admirable that was, it was extremely challenging for them. And unfortunately, they did under-recruit, because the complexity of the NHS organisations, and there were various challenges along the way with changing organisational boundaries, meant that ultimately it was so challenging to completely fit with the end clinical services from the outset, that it was they weren't able to recruit to target. And I think that shows the difficult balance we have to tread, because before there is a full evidence base for an intervention, it's very difficult to persuade a clinical service to prioritise it, and thus some level of research, organisation, delivery is needed. But how do we make that as close as possible to the end use? This is another interesting example of looking at how did these research findings, how do we actually implement them in practice? And this is a very interesting study by Appelhoff, who looked at an organisation for special care units and care homes for people with dementia, and really sort of outline the detail, and of course it's in the detail that decisions are made about how well interventions are implemented. And in this example that they talk about, the intervention that was being delivered actually competed with a current working method that actually people were quite attached to, and it required a degree of duplication, and so it wasn't always a good fit, and this did limit the degree of implementation. And the other thing that it is important to think about right from the outset is how your ultimate intervention, if it works, is going to fit into organisation structures and cultures. And we saw this very much in the when doing research in care homes, that when you have organisations with staff shortages, high turnover, multiple organisational changes, it can be very difficult to persuade people to adopt new practices. And one of the key things is very much to ensure you can be persuasive that this is something that fits with their priorities, and you can get staff to really have a belief in the benefit of it. It can be very helpful when you're designing studies to have champions within an organisation that you are particularly in touch with, so that they can disseminate your message to people in that clinical setting. But one thing that I think is very interesting from this study, and how we have to keep thinking, is that they appointed one champion, but of course if that champion is less competent or departs, that can negatively impact. So it's important to have two champions, and that was a very simple but deliverable on recommendation that we have taken forward. What I have in both the trials that I lead at the moment, and I think is becoming standard practice, is an implementation group of people from a variety of organisations that you expect to adopt your results if they are successful, involved from the outset. So for the Alneida's family intervention for people living with dementia and family carers, this group includes family carers, commissioners of NHS services, local care home leaders, so that you can have that critical friend along the way, ensuring that you don't perhaps make decisions about how you are going to deliver or organise your intervention, which might limit its later accessibility. So in the last part of my talk, I'm just going to describe how in our current study, NIDA's family, we're trying to put some of this thinking into action to do an effective process evaluation, to really have a good evidence base for how, if our intervention works, it will be deliverable. And we are basing this on the UK MRC guidance for process evaluations, but I think this is quite universal, in which the more you can understand the context in which you are trialling your intervention, the more you can understand how you expect it to work and what are the important core parts of the intervention and how you can be flexible and how it actually works to deliver your outcomes. The more you can understand about that, the more it is possible to advise people how to implement your findings. So this is our NIDA's family intervention, which is actually drawn on lots of the global research. This is an intervention that is very pragmatic and is delivered to family carers and people living with dementia as dyads, but in a very flexible way, so that if for people with more moderate and severe dementia, it's often appropriate for it to be delivered entirely to the family carer. When the dementia is more mild, it is delivered to both. And family carers and people living with dementia set goals using Ken Rockwood's goal attainment scaling strategy. And we ask them, what do you think will make the most difference to the person living with dementia being able to live as well as possible and for as long as possible in their own home? And in our trial, that is our main outcome. And people allocated to the intervention group then have a first intervention session in which those goals are refined. And the deliverers, who are psychology graduates without formal training, who are clinically supervised, then map those goals to a number of structured modules, which are very much based on the best available evidence that you've already seen. So, for example, very commonly behaviour problems are identified as a real sticking point to somebody staying at home. And we're lucky enough to be working with Helen Cales, and we have the DICE approach, which you've already heard of, as our main strategy for behavioural management. We have other enabling strategies. You've heard about OT approaches already. And then there's obviously some psychoeducation about forward planning, some carer well-being. There's a range of possible structured manuals that are fitted to the goals that people want to work on, and then they're supported to put things together in a forward plan, and then the psychology graduate checks in on them over the course of a year to see how they're getting on. So the way we're approaching our process evaluation, this is a little bit of a mess, but then interventions are complex. And these different mechanisms that I've talked about all work in different ways to achieve the ultimate short-term goals, because we hope to ultimately increase the amount of time that people can live well at home. But that is the long-term goal. In the short term, we hope to do this by decreasing carers' stress, improving communication, and decreasing neuropsychiatric symptoms, to name but a few. And we hope that people will be able to achieve the goals that they set because they believe those goals would help the person to live longer at home. Now, that's not going to be perfectly aligned with living well at home because life is complicated, but we hope that that will be a good staging post towards our ultimate outcome of increasing time lived at home. And so this is, put another way, how we will be looking at this, thinking about the context in which we are delivering our intervention, and thinking carefully about the mechanisms through which it will act to deliver those outcomes. So this is a trial. We're planning to recruit 300 people. We're up to 66 today, I've just heard. But this trial began in April 2020. And in the UK, we went into lockdown on the 23rd of March. So this trial has been delivered 85% on Zoom and 15% on the telephone. So to our, not what we expected, but this has been a remote intervention. And of course, that brings challenges, but it also brings real opportunities. And we have recruited over a much wider area of the UK than we would ever have expected, because we've been enabled to do that. And thus far, our dropout has been extremely low. And I do think to some extent that might be the convenience of the remote Zoom delivery, which we would not have thought of doing before this. The context, obviously, this is a very flexible intervention, which is going to be very much guided by the level of dementia severity and the relationship between the family carer and the person with dementia. Currently, we have just got in press in Ageing and Mental Health, our initial pilot of this, and in about 2/3 of cases, this intervention was in fact delivered entirely to the family carer, but with some involvement of the person living with dementia in other cases. So that's quite a busy slide, which I won't go through in full, but these are complex interventions. And if we are going to take all the information we can from trials to bridge that gap to practice, it's important to think in detail about the decisions that we're making, and if it's worked, how it has worked. And as I said before, we have our implementation group thinking all along the way about how this is going to translate into practice. So in summary, how do we best bridge that gap between research and practice? We need to keep working on the representativeness of our research populations. Interestingly, I do feel that our entirely remote delivery has restructured inequalities. We have some people who have said that they wouldn't have taken part of before, but that certainly something about the accessibility of being able to access this from their own home was very helpful. Whereas we are, to some extent, we're trying very hard, but there is an inevitability about excluding people who perhaps have less digital connectivity. How the intervention is developed needs to be feasible, and it needs to be something that can translate easily to the real world. We're trying very hard to involve end users from the outset. And with all of these interventions, when you start to think about the causal assumptions and how you expect them to be working, you come to a complex web, and that is the reality. And it is very complicated thinking about how we are enacting change, but spending time really drawing that out has, we found, been very helpful to our thinking. Thank you very much.
Thank you so much, Claudia. I really like the way that you illustrated the principles of knowledge translation to the project you're working on currently. And I liked even more the thought that you've drawn on global lessons and have done it in a very pragmatic way in trying to make your approach very person-centered, responding to people's needs. And maybe like COVID more generally, the fact that we've been forced into virtual experiences will give us some positives in the research translation area as well. So thank you very much. So maybe we can move on now to Professor Henry Brodaty, who will be known to many of you from the University of New South Wales. Henry's got the opportunity of responding to our speakers and to draw on his own extensive research experience. Over to you, Henry.
Thanks, Glenn, and thank you, ADI. And what a great panel of speakers. It's been quite inspiring, and we've been very lucky to have people who are leaders in the field talking about this. And so my task is to try and bring all this together and say, where next? What's happening next? So what do we know? Well, we know the carers of people living with dementia. We know quite a little about it. We know, and this is going back now to the 1980s, dementia is not just one person's illness, it's the whole family. We know carers have higher levels of stress, depression, and burden more than the peers who are not providing care. What we haven't talked about is that some carers are not stressed, but find the care quite rewarding, or can have both stress and find it rewarding. They find the reciprocity of being able to repay a lifetime of being together and brownie points built up, the love, altruism can drive them to be doing things for their loved one. We know that carer stress and people living with dementia, stress or anxiety, depression are associated. We also know that carers' needs vary with the stage of dementia, and we saw that with Laura's slide. We also know from Laura and from Rose-Marie that what carers want and what carers need might not always be the same. They mostly want respite care, practical help, emotional support, access to services. They don't always access those things. We haven't heard much about key workers and navigators along the path of dementia. This is something I'm quite interested in. And these provide proactive, consistent, and continuous care and guidance rather than non-reactive, episodic, and having a different person each time. The dementia advisors that Rose-Marie mentioned from Netherlands are perhaps related to this. And of course, in an ADI meeting, we have to talk about the role of Alzheimer's associations and the support information they provide. So what do we know about carers? Well, we know there are interventions, and we saw lots of examples over these three talks. Some great examples from the United States, from Europe, from the UK. And we have a lot of evidence that interventions can reduce caregiver stress or carer stress, their burden, depression / anxiety. There's some evidence that earlier may be better. There's a lot more evidence that multimodal or multi-component is better. In our own research, we find involving the whole family and their support system is really important. And going back to Chris Gillard's book, which inspired me back in the early 80s, informal carers informal networks seem to work better than having the formal networks. But we as researchers, of course, bring in our formal services, and it's a challenge for us to try and meld the two. Really important is that carer support, care interventions are cost effective. This is really important if we're wanting to try and get policymakers, governments to take these on board. And one of the most important ways they can be cost effective is delaying nursing home admission. You know, a care home is an expensive place to go. People want to stay at home. Families want their loved ones to stay at home by and large. And so this is a very powerful tool. Interventions improve caregiver knowledge. We did a meta-analysis some years ago looking at carers as therapists. And we showed for reduction of behaviours that empowering the carer to help with those behaviours was effective. And Laura's work using the TAP program has shown this as well. So over the years, we saw that lovely evolution of caregiver interventions from Rose-Marie, that the repertoire of interventions and the complexity has been increasing. And we saw from Laura's work, the quality and the quantity of that research is improving as well. And there are multiple benefits. In Jill Livingston's Lancet Commission article, we saw there are benefits in multiple domains, as I've just described. So it's all positive. But not everything is all positive. You know, if we tell GPs, for example, there are these fantastic programs for family carers, very few get referred. Why aren't these interventions being prescribed? They'll prescribe a prescription for a cholinesterase inhibitor, but not a referral to the Alzheimer's Association, which is offering a carer training program. It may not just be the lack of referrals, it may be a lack of availability. So how do we convince GPs and other healthcare professionals to engage with these carer interventions? And from the people with dementia and their family carers, who often are looking for this magic bullet. They want the pill. They don't want to accept this is where we are and how can we live with it, have a very positive quality of life. We're not very good at reaching carers, particularly the minority groups. The people in my country who don't speak English as a first language. People with young onset dementia don't mix well, and their families, carers, with the general population of people with dementia. We've not really discussed intellectual disability, where there's a much higher rate of dementia. And we've been talking about carers, but a substantial proportion of people with dementia live alone. If they've got a carer, the carer's in another place, another city, another country sometimes. And each of the speakers has highlighted how do we translate these research projects from that setting into the real world. So where to now? Well, online interventions. We heard from Laura, we heard from Rose-Marie, we saw the WeCare Advisor, we saw the apps that Rose-Marie's developing. Some of them in real time. I love that SciMate that you talked about, Rose-Marie. We saw many creative strategies involving people with dementia and their carers in doing things together. And it's not only the person with dementia who feels better, the carer feels better. That Museum of Modern Art, there have been choirs, singing groups with the people with dementia and the family carer in the same group. And reminiscence therapy has been going for a long time, the same sort of process. Giving the carer some structure on how to do things with the person, and the TAP program does this as well. We adapted a program we did in the 1980s where we did a 10-day course for people with dementia and their family carers. And we showed we could delay nursing home admission, reduce carer stress. And recently, Meredith Gresham and I and others, we adapted this and combined it with respite care, where instead of the person with dementia going into a residential facility for respite, they went in with the family carer for 5 days and ran the program during that time. And we showed it in the comparison group, we delayed nursing home admission. And what's more important, an independent group picked up this program and costed it and showed investing in this program would save our government, which funds a lot of nursing home care, hundreds of thousands or millions of dollars, really. There are other creative programs, such as integrating with children in kindergartens. There are in-home interventions, particularly with OTs and the work of Laura Maud-Gruff from the Netherlands and Claire O'Connor here in Sydney are all examples of that. We've been particularly interested in this post-diagnostic care, and we've got a project currently underway called Cognizance, working with the UK, Netherlands, Poland, Canada, Australia, developing this and hoping it'll be something that can be used globally over time. We'll be finished in about 1.5 years. But one of the core principles of this is reablement. Like after a stroke, there's a rehab program. After a diagnosis of dementia, get your affairs in order. So we're looking at reablement, and carers can be partners in this, as they should be in hospital care where there are lots of problems and in residential care. So where to now? This is my hobby horse. You know, we've been seduced, we've been intrigued by precision medicine. We see it in breast cancer. Your genomics can decide which drug you should be taking for the breast cancer. It's called pharmacogenomics. It's the precision of matching the intervention to the person's needs. Well, maybe one of the reasons multi-component interventions work is because we're not very good at working out exactly what the person needs or them telling us what they would like. So we have to match to so many variables: the carer variables, the person with dementia variables, the relationship variables, the dementia variables, the supports and the context, as we've heard. Where to now? Better systems, integrating with other services, with electronic health records and with medical care. And as Claudia beautifully demonstrated, the challenge of translating the research into practice. So there's some very practical things we could address here. Can we reimburse practitioners adequately for their time? Can we encourage government to look at policy and realize if they make an investment, they'll get a positive return. They'll get dollars worth of return for every dollar invested. And how do we make these programs adaptable globally? We know 2/3 of the world's population with dementia are in the developing world. There are some fantastic projects that Martin Prince's, I was going to call him Martin King, he hasn't been promoted yet. Martin Prince's group have been doing the 1066 groups in India, in Russia, in Latin America, working with family carers. There's a WHO I Support network, which has also been mentioned today. So there is a lot happening, and there's a lot more that can be happening. And clearly, carers are an important part of the package in how we support people with dementia. And a carer who feels empowered, who feels positive, will have a person that they're caring for who also feels better and more positive and will stay at home longer. It'll be better for them, it'll be better for the country, it'll be better for their economy. And it's something we should all be striving for. Thank you.
Many thanks, Henry, for those wide-ranging perspectives, and perhaps to thank you too for all you've done for ADI in the past and for your contribution to the conceptual and practical ways of thinking about support for carers. I suppose I can only conclude with two thoughts, because Henry's said a lot of things which bear repeating, but we don't have the time. The first is that we clearly have a lot of work to do in actually involving policymakers and service providers with researchers, looking at the evidence and building it into practical ways of assisting people with dementia and their carers. But perhaps my hobby horse is answering or trying to answer that question that Henry asked about how do we get these interventions more prominently in the mind of health professionals? And I think there are only two answers to that. One is to ensure that aged care and health are brought much more closely together. The other that I feel strongly about is that carers and people with dementia should actually have rights to the care and support they need. So post-diagnosis, for example, carers and people with dementia should have a right to support, a right to information that will get them on the right track in terms of thinking about the future with dementia. So it remains for me to thank our presenters. I think they've all done a wonderful job. I had the ambition of having a segment at this virtual conference that informed people about where research is at and the obstacles and barriers in knowledge translation. And I think we've had a wonderful session today from our presenters. So I hope our participants have found it as useful and interesting as I have. And I hope they have an enjoyable conference and enjoy the other many wonderful sessions that will take place during this first ADI virtual conference. Goodbye and thank you.